Okay, thank you. We have before us the minutes of the special meeting held on June 13th and the special meeting held on July 10th. I think we probably need to take these one at a time. I believe that these minutes have been provided electronically to all the board members some time ago. Hopefully you've had an opportunity to review them, and I would entertain a motion to accept the minutes for the June 13th meeting unless there are some changes that need to be made. Any comments? Questions? Yes?
I think there is a correction that needs to be made on page 2, line 2. It's a statement that you made, Chairman. Say, Mr. Carpenter related that their legislation requires them to audit. I think it should be our and us if you want to change that.
Say that again. Mr. Carpenter related that our legislation requires us.
Well, we were talking about our legislation compared to West Volusia, and then you went on to ask them if they have similar requirements.
Okay.
I mean, if you want to change it, I think it reads better.
That's fine with me.
Is that the June 13th or July?
June 13th, page 2, line 2. Changing the word there to our and the word them to us.
Page 2.
And then on page 6 of July 10th meeting.
July
10th, page 6. Line 23. The acronym HCCRA. I think it's supposed to be HCRA.
for the HICRA?
Healthcare Responsibility Act.
Yes, okay.
Okay, there's another spot too that we have that double C. It's on page 7, line 33.
Okay. Any other changes? Did you get those two changes on the?
Yes, as you can see, so that I think if I must stop at the sheet somewhere, I'll look it up and see if that's the action or not.
Okay.
Usually I would look this up.
It's Healthcare Responsibility Act, I believe. So I don't know where the second C would come from, but I'll leave it to your judgment whether it needs to be changed. If HCCRA is correct, then leave it as is, but if not, let's change it to HCRA. Any other recommended changes? All right, hearing none, I guess since we've kind of covered both of them, I'll entertain a motion to approve those minutes.
So moved.
We have a motion by Mr. Myers. Have a second?
Second.
Second by Ms. Maynard. Any further discussion? All in favor, please signify by saying aye.
Aye.
Opposed likewise. Motion passes. The minutes are accepted. Next is the catch-all section of the agenda, where we're indicating further discussion on the implementation of procedures necessary for compliance with House Bill 1299. One item that I inadvertently left out was Mr. Chet Ross from Schumacher, Johnson and Ross had asked to be put on the agenda to discuss an engagement letter. I believe that everybody should have received a copy of the engagement letter tonight. It's several pages long, but I'd like to ask Chet to come up and discuss any changes that have been made. And we don't necessarily have to agree to it tonight. We might want to take it and look at it, but at least it'll, Chet's comments will give us something to think about while we look at it, and then we can approve it.
I understand. Thank you for seeing me tonight and seeing me early. I have presented my contract for audit services for a 3-year period, and I had originally drafted it back in January and thought I was going to get to be at that meeting, but it wasn't on the agenda that meeting. But that is what the underlying 5-page contract is the original engagement letter. The addendum that I've attached to the top is what I drafted for this meeting, and that since I drafted the original letter, the legislation was approved, which will change change the scope of auditing this hospital district. And so what I am asking for in the addendum is that the pricing that I've listed in the 3-year contract, I will only hold for this fiscal year, because I expect that what I need to do this year would be the same as I've been doing over the past 20 years or so. But I will come back to the board after that year, after you have gone through and determined how all this is going to play out, how things are going to be done, what type of controls and everything need to be in place, and what I need to do. And I'll come back with an estimate after that gets all done next year with pricing, and would try to come to an agreeable contract on those 2 years at that time. I know that you just got the contract, so I understand you won't be voting on it tonight, and I'm fine with that if you have a meeting next month. So all I'm trying to do here, I'm trying to be short because I know you have a very heavy agenda, is just present what's there for you to look at, and then I can come back next month and if you need me for questions or anything else to prove it. Do you have any questions right now?
Would there be any reason why we wouldn't just make this a 1-year contract and then negotiate a 3-year deal next year?
I could do that too. I had already drafted the letter, and that's why, and I thought it was going to be here. I thought everybody had received that already, so that's why I drafted it in this manner. I can do it that way too, however we want to do that.
Okay.
Question? Yes.
We were paying $4,000 a year, right?
Mm-hmm.
Okay. If it's pretty much going to be the same for this year's audit, then why do you feel that you need to raise it to the $800?
Because it took me more than I expected that last year, and this additional price increase will cover what I think will be enough to do this year's audit.
It's the shortest audit that I've ever seen on the auditor's website for a special district.
It's not a difficult audit, but audits are very expensive too. It doesn't take long to run up a $20,000 bill on an audit.
Are there any other questions for Mr. Ross? All right, hearing none, I appreciate you bringing this forward, and I would suggest that we add this to the agenda for our first budget meeting in September, so we can discuss this in further detail. And I think that will pretty much cover it. All right.
Thank you very much.
Thank you.
I'll see you in September.
All right. Next on the agenda, since our last special meeting in July, I was approached by a couple of sources associated with free primary care clinics. One of which was St. Luke Free Medical and Dental Clinic, and I did, in fact, I think, pass along or have requested the executive summary of the proposal or submission of information that I received. I think that everybody should have received a copy of that in the last couple of days anyway. And I know that Ms. Berry is here in the audience, and I would ask her to come up and make some comments, if she would, and then we can ask questions thereafter.
Thank you, Mr. Chairman. My name is Karen Berry, and I serve as the Vice President of Catholic Charities of Central Florida. We serve a 9-county service area. Our mission is to provide vital social services to the needy, the poor, the hungry, the hurting, the helpless, and we do that to 120,000 people every single year. We have 39 programs, and one of the most important is our free medical clinics. We have 3, and they're all in areas of critical need within our 9-county area, one of which is located right here in Eustis, called St. Luke's Free Medical, and it's our first dental clinic as well. And this clinic was the dream of several faith-based organizations and doctors and dentists who came together and decided that they could do something to serve the very poor, the indigent, and those without any insurance whatsoever. And so We started in June of 2010, and in this year and a half, we have served just this fiscal year 934, 500 some in last year. Our services have doubled in the past year, and so our doctors and dentists would like to expand the service provision that we currently have. We originally thought it was going to be urgent care and that we would then refer these patients out, but what we are finding is that we have become the medical home for these patients. Again, none of them have insurance. We're a sovereign immunity provider agency, as your enabling legislation shows that is an approved program under this legislation. As such, we do not charge anything for our services, nor do any of our medical or dental professionals get any remuneration for any services provided. So what we're asking for and hoping that perhaps under this enabling legislation we could be considered for some of the taxing money from the taxpayers of Lake County. We understand that not all of our patients would qualify because the requirements of your grant under the Responsibility Act and the standards are very limiting, and it would also require a lot more paperwork. But we do have 87%, almost 90% of our patient load that would qualify. And so we were very encouraged by that research that we did. So I'm here this evening just to answer any questions. I provided all of you with an executive summary which lays out the basics of what we're looking for. We would use this funding primarily to expand our surgical fleet. We have currently an LIP grant thanks to your wonderful Lake County Health Department who brought us all together in a Lake Health Partnership. So I'm not the only free clinic in your service area, but we want to expand to have an outpatient surgical suite with volunteer doctors covered under sovereign immunity, as well as an additional dental suite, so that we can serve more dental patients. And as you all are well aware from the Department of Health survey that's done every year, and I participate in that group, dental services is a great need in Lake County, and particularly for those they don't have insurance to cover. So I'll be happy to take any questions. I have with me tonight our medical director, Dr. Kevin Taylor, and I also have Dr. Don Ilka. And by the way, Dr. Ilka was just made Dentist of the Year for the state of Florida thanks to his work at St. Luke's.
Great, congratulations.
So we're very excited about it.
I have a couple of questions, and I believe in our personal conversations I've already talked about it with you a little bit, but I'd like for you to maybe share with the rest of the board. Number one, I think that the terminology or the language in the current legislation, the new legislation, specifically says that we're able to reimburse or pay for indigent care at the rate of the lower of cost or Medicare reimbursement for the services provided. And I don't believe that there is a Medicare reimbursement for dental care. And I don't know if that is going to be an issue. Maybe Dr. Ilka can address that. And if you could, if you want to come up to the mic.
You are correct. There is no Medicare reimbursement for dental treatment. There is very limited Medicaid reimbursement for dental treatment for adults.
Okay. That's what I was afraid of. The legislation indicates that we can't have individuals that receive or participate in part of another government program, which I would presume would include Medicaid and Medicare, number one, or Medicaid. And the reimbursement side, this is a part of and you haven't been in the last couple of meetings, but this is a part of the legislation that we've been struggling with and how we can comply with the requirements as it's currently written. it's been very difficult for us, number one, to identify a licensed primary care clinic. In and of itself, there is no such license out there that we're aware of. And then two, how to preserve the sovereign immunity for the volunteers that are volunteering their time within the clinic, if in fact the reimbursement is lower of cost or Medicare reimbursement for services provided, for patient visits, so to speak, I think. So I think that I know that I'm going to recommend that there be some changes to the legislation be made, and that was actually part of the legislation that was approved. They requested that the board make a report at the end of the year suggesting any changes to the legislation that could make it better, and I think that is definitely an area where we can improve the language. We're going to hear some information later on that's going to talk about a possible way out of that to preserve the sovereign immunity with a lump sum payment as opposed to reimbursement for visits or for services provided. But then again, it's not really what is specifically identified within the legislation. So we're still struggling with that. At least I am in my mind. I would definitely like to be able to help. But I think that what I would recommend is that for the worst case scenario, I think we can consider the reimbursement for the non-dental at least first. And Ms. Berry, you mentioned before that you wanted to use the funds for the expansion of your facility, and they can't be designated specifically for the expansion of your facility. I mean, you can use the reimbursement that you get or any tax proceeds you get, in any way you want. I know that you get contributions from multiple sources throughout the year, and hopefully that's going to continue. The excess money that you get from us, it's all going into one pot, and you can kind of take the dollars out of there as you wish for the expansion. But I don't think that we can, as the legislation is currently written, I don't believe that we can specifically identify tax proceeds to help you with the expansion. It would be for the reimbursement of care to the indigents as identified and described within the legislation. And you believe that you won't have a problem in coming up with the required documentation under the HICRA guidelines. You said 87%, you think?
Yes, sir, 87% from FY12. We went to every patient and looked at every patient, and almost all of them have the documentation that's required. So that satisfies that need. Plus, we also researched those that reside. You have to prove your residency in North Lake County, and so we have 87% of them. And as far as the operational budget, I'm certainly no expert in this, but
we are
if you may want to consider perhaps using something that we do on the LIP grant, and we receive state funding, and there is like a minimal threshold of patients that we must see and must do case management on every single month. And there is paperwork attached to that we must submit to the grant in order to get the lump sum that you talk about for operational. So that you may want to consider not totally changing the legislative language, but maybe defining it, maybe a threshold, maybe a grouping, maybe a number, a minimum number, and that may satisfy the intent of the legislation without compromising it. The other thing is that we fundraise almost $50,000 a year. We would allocate that specifically for the expansion and use the monies given to us for operational needs. We do have other resources, but this would allow us to expand the services that we have. As far as dental, I'm wondering, because your entire county has come together and said dental is a crying need here, if it wouldn't be worth your attention to perhaps add dental to that legislation. If you're going to recommend making some implementation changes, perhaps that would be one of the things you may want to consider, because our dental is 7 months waiting list, and it's not, I don't think, going to get any better. So, and these are all extractions, correct me if I'm wrong, but primarily they're all extractions, which is the most expensive kind of dental procedure that is very, very expensive. So we save our taxpayers so much money. And the other thing is that our main goal is to keep patients out of the emergency department because it's so expensive, and we work very closely with our hospitals to try to do that. This would even make it better.
Can I make one comment about that? The literature that came out about 2 months ago said that nationwide we're $800 million spent in hospital emergency rooms absorbed by the states for purely dental treatment. And there are instances where Medicare would cover some dentistry from the standpoint of acute infection, size of drain, some surgical procedures to alleviate pain and suffering. But that $800 million nationwide, and I don't have any specifics for the state of Florida, but I'm sure that it's pretty significant.
Now, any of those procedures that you said might be reimbursable by Medicare performed in that clinic?
Are they performed? Yes.
Okay. Okay.
Yes. Chairman, I was on the internet and I was trying to find the definition of medically necessary services, and what popped up was American Academy of Pediatric Dentistry, and of course my doctor thinks that my teeth are very important to my health, but this article goes on to say the same thing, that this is a medically necessary treatment of dentistry. So I probably didn't give it to you, but I have some questions for Karen. And Karen, I want to thank you and thank St. Louis for everything that you're doing. We appreciate it for the citizens of Lake County that are in need.
It's our privilege to do that.
In this printed article, it says there's a coalition of faith-based organizations in Lake County. Can you tell me what that coalition is?
I can tell you about our coalition. I don't know about the coalition.
Oh.
I know that we engage a lot of our brothers and sisters in other faiths, as well as the hospitals that also have a faith-based mission, and we try to work together. It's not a formalized coalition that I know of. At least they haven't told me that. But whenever we work on projects, it just seems like we all gather in the room for, like the Department of Health survey, we all come and Livestream is another one that's not been mentioned, but they also do a tremendous job here with mental health, which, as you know, is another urgent need. So as far as form of coalition, I can tell you we have multiple faiths.
Okay,
That I can tell you.
I was wondering if the Methodists might be involved in that.
Yes, actually, we have engaged that faith as well as some others, the Baptists. I have some great interactions with our Baptist brothers and sisters, so yeah.
Something else I want to ask is that this program provides sovereign immunity for the clinics located in the designated AHCA, is that Agency for Healthcare Administration, area of critical need in Eustis?
Yes, ma'am.
I tried to find that on the website.
It's ACA. ACA really
Yeah.
oversees all of what we do under sovereign immunity through the Florida Department of Health. So ACA is that oversight agency that calls the shots, the rules, and regs.
So you have sovereign immunity already, is what the clinic itself.
Yes, ma'am.
Because we've had some discussions about that, what would happen, the way the bill is written with sovereign immunity for those doctors and volunteers that are just contributing their time.
Well, I can tell you this. If we were to lose our sovereign immunity because of the per patient pay rate, we would immediately have to close our clinic. The only way that we could survive as a sovereign immunity provider agency in Catholic Charities of Central Florida is the actual provider agency. Underneath of that, we have 3 clinics covered, and our doctors and our nurses covered, our professionals, and our dentists as well. And so if we were to lose that, we would immediately have to close because we could never afford as an agency to pay for the onerous liability policies that would be required for 24 doctors and nurses. How would we ever do that?
there's going to be some information presented shortly that actually discusses that a little bit further.
And then the article goes on to say currently the wait list is 4 months for medical and 7 months for dental services. It seems to me like there is a tremendous need, because I heard the director of We Care say that they have scheduled appointments for patients in January, and this is only August, so
We're the same.
The need.
We work very closely with We Care. We work very closely with our hospitals. But again, the goal is to keep them out of the ED and try to take care of them, triage them there, get them stabilized, get them referred on. The one thing I didn't mention in the executive summary, and the one thing that I talked to another clinic today about on the way up here, was that we have an incredible scarcity of diagnostics and labs, which, as you can imagine, even at the Medicare rate, it's very expensive. One invoice that I have here today was $1,100 for diagnostics, simple diagnostics on 3 patients. That's at the Medicare rate. That's not even at the retail rate. And so we were talking today that the one thing that we really need is the diagnostics and labs. Now, we all, in our coalition of the Lake Health Partnership under Department of Health, the one thing that we do have is that we negotiate with our labs and our local. It's all local, every bit of it is local. The Vista, the physicians, imaging, Bay Pharmacy, all of that is the lowest rate we can go. But when you have 3 patients at $1,100, where are we going to get that money? So part of our urgency is that you can take a patient and Dr. Taylor can treat them, and he orders diagnostics, and if they won't go because they can't pay, what is he going to do? Correct me if I'm wrong, Doc.
I'm Kevin Taylor. I'm the medical director there. Karen is describing the situation accurately. One of our big problems, and I guess it's something that you guys are grappling with, although I haven't been to your meeting, is what all of us see, what the hospitals see, what the hospital's clinics see, the other free clinics see, We Care sees. We get patients coming in. We identify, we make diagnoses, we identify the problems, but then what? What do you do at that point? You write prescriptions, we're very conscientious or we're very cognizant, is a better word, about the patient's financial issues. And so, we try to treat them with any generics that are there, any $5, $4 formulary medicines we can. We've worked out deals with the labs and some of the x-ray places to get them way below what the regular cost is of basic lab work and things. But then what? First of all, the patients have a hard time even affording that kind of thing. And then what kind of follow-up are you going to get? One of the big backlogs we have in our clinic is we'll identify problems on multiple patients or multiple problems on one patient, and then try and refer them to We Care to get something done. But We Care has this incredible backlog. And so this is one of the things that we would like to hopefully get some better coordination of whatever limited resources there are here in the county to get the people moving along. And I know everybody's working towards that. I will also echo what Karen said. If we do not maintain our sovereign immunity, I think this holds true for the hospital-free clinic as well. I don't know about Leesburg's free clinic, but if we don't maintain sovereign immunity, we just won't function. The doctors will not be able to work there. So I know you guys don't totally have all the answers to that one yet, but I know you're going to work on that, and I appreciate any. I know our volunteers and also our patients will appreciate anything that you guys can do to help us. So, and if you have any other questions, You can call me at my office, you can ask me tonight, I'll be happy to talk to you.
Thank you, Dr. Taylor.
Again, I have another question.
Sure.
It also says here that St. Luke's is the licensed medical facility under the Florida Department of Health. Now, we've been grappling with licensed healthcare facilities and trying to decide what the legislation meant. So can you tell me the difference between the statute on license
I cannot.
that you have to be licensed with Agency for Healthcare Administration?
I know that we work closely with Joyce, I don't know, at through the Florida Department of Health. And, you know, in terms of setting up whatever the paperwork we needed to fill out, make certain that we fulfilled all the state requirements. And I would just point you, Karen probably knows more about that, and I'll let her address that. But also, I would point you towards this individual that we've been working with, and she can probably tell you a heck of a lot more than I can, and she is with the Florida Department of Health. So, the other thing I would also say, one thing about the dental. I would say it's been my experience and the experience of most of the other physicians there is that probably somewhere in the neighborhood of between 70 to 80% of the medical patients we see have acute dental needs. The minute you ask them to say ah and open their mouth, it's very apparent. And I will say that the dental treatment, we then, you know, obviously make them an appointment in our clinic to have their needs taken care of to the best that we're able to. It's amazing how many other issues regarding their medical health start to clear up once you take care of their dental needs. So, any other questions? Thanks.
All right. Any closing remarks, Karen?
What may help you afterwards, I could give you a copy of the license that we get from the Department of Florida Department of Health, and I think it actually, because of sovereign immunity, is called an exemption. You see in my note I have license number, exemption number. I have a copy of that I can give you after.
Well, if you would provide that information, and I'd like to ask our board attorney to maybe follow up on that for us. She's already done some research on it previously.
Be happy to do that. My closing comments is I know your job is really complicated and very challenging. We really appreciate you trying to help us, help all of us to serve the needs of the indigent. It is not easy, and we thank you for your support.
Thanks. I mean, I would echo that, and I don't think anybody up here is trying to find a way not to support one of these free clinics. I think we're trying just the opposite, trying to find a way that we can direct the funds to them, but staying within the guidelines of the new legislation. Because there was so much conversation about sovereign immunity in that presentation, I'd like to ask Mr. Madison to come forward. Florida Hospital Waterman has been looking into that issue with the state's attorney's office in Tallahassee, I believe. So you want to provide some update on that?
Madison for the Hospital Waterman. The name Joyce Kofel has been referenced already today. Joyce is an employee of the state of Florida responsible for our region, and we have been working through her office to try and get from the state attorney's office a ruling, a determination about this whole issue of sovereign immunity. And the very latest, as of the 19th of August, which is the last email that I have from Joyce, basically she's talked with the attorney, but the attorney has not yet provided something in writing to help clarify the issue. Unfortunately, the verbal responses that we've gotten from her regarding the attorney's perspective is that regardless of what exists in the enabling legislation, if the money is tracked to a specific patient, the state's opinion is that sovereign immunity goes away. But if it can be tracked, if it is in bulk or in a lump sum, but doesn't track specific patients, sovereign immunity can protected. I am delighted that there may be options that allow for the Taxing District Board, if possible, to interpret the enabling legislation to allow for block payments if that can be possible. Because then I believe that both clinics would be interested, all three clinics would be interested in finding ways to provide requests for reimbursement. It is imperative to make it clear, and it has already been made clear by the two physicians here, all of the providers that I have spoken to make it clear that the minute they lose sovereign immunity, they are unwilling to provide their volunteer services. And without volunteer services, any of these free clinics are not an option. We just cannot continue to operate them.
Mr. Chairman?
Yes.
I am totally confused because you keep saying state attorney. Do you mean state attorney? That's the office that investigates criminal? Do you mean attorney general rather than state attorney?
We have been going through Joyce Kofel from the Department of Health, and she has been seeking clarification regarding that. Let me see if I have anything here. I cannot define for you which state attorney's office she is referencing at this point.
It couldn't be the state attorney, Meredith, right? Would have to be the attorney general.
I believe it's the attorney for the Department of Health, is my understanding, not the state attorney that you're referencing that investigates the criminal actions of the state.
This would be the legal representative for the Department of Health that concerns itself with the sovereign immunity issue.
Okay.
So when they reference state attorney, it's an attorney that works for the state, not the, quote, state attorney.
Okay, good.
Okay.
Because that was pretty misleading to me.
It is not my intent to mislead you, Mr. Mayor.
I'm sure.
Ever.
I'm sure. Right.
All right. Thank you very much.
Thank you.
My understanding of the Attorney General is if we want an opinion from the Attorney General, then the entire board would have to ask. We would have to make a motion and the board would have to ask.
That's my understanding as well. But it sounds to me like that's already underway. Are you expecting a written response from that attorney's office?
Yes, we are.
Okay.
And we've requested it for several months now. For some reason, it's just not been working.
Hopefully we'll have something by the September budget meeting. So.
We will continue trying.
I appreciate your effort. Okay. Next on the agenda, Mr. John Terry, President of Lifestream Behavioral Center, wanted to make a presentation about some primary care that they offer their mental health patients. We think that it may be, or he thinks it may be qualifying under the current statute language.
Thank you, Mr. Chairman. Board members, I just want to bring you up to date. I talked with you last month about the great disparity there is in the provision of primary care for the populations we serve, which are individuals with mental illness versus the general population. And I had told you that we had found dollars to open a primary care clinic in the Leesburg area. It's through a federal grant. The very next week after you met last month, it was brought to my attention that there might be an opportunity to apply for dollars from ACA under the LIP program that you've been discussing. And so that was a program that we had not been able to access before, and we have about a week to look into it and get an application in. But we did that, and what we found was the state has about $20 million available statewide for new projects, and there were strict criteria that were attached to that. But once we looked into it, we found that we were eligible. So we talked with the folks at ACA and actually did put together a proposal, which I will be glad to get you a copy of. The proposal that we put together was to expand the primary care services that we provide in Leesburg to Eustis by creating a new clinic there for individuals in that area. We would like down the road to also be able to expand to our outpatient clinic in the Claremont area. but this opportunity was for Eustis. So the total cost of this clinic would be $320,000 per year. If it's approved, which I think is a long shot, but if it is, it would take $134,000 or so of local dollars, and those dollars could be certified to bring down an additional $184,000 from ACA through the LIP program. So it's about 1.4 new dollars for every dollar that would be put in. If we can clear up the question of this certified clinic, and I believe we would qualify. We, as you know, presently receive dollars from the taxing board for our inpatient services, 5% of the available dollars. But again, we would hope that if we are successful, and we will know by September 15th whether we have it or not, that we would be able to receive the $134,000 or so from the taxing district in order to create a primary care clinic to serve the individuals we are already serving who have mental illness for their primary care needs in the Eustis area.
Did you indicate that you're already a recipient of federal dollars from a...
We do have a federal grant. It's a unique grant. There were 56 grantees out of 400 throughout the nation who were approved. We were one of 6 in Florida, and so we are currently being funded to provide primary care services, again, to the individuals with mental illness that we are already serving, but in an integrated clinic in the Leesburg area.
Specifically for Leesburg?
Yes.
Okay. So the dollars you'd be asking for from the tax district would be for a separate location?
Specifically for a clinic in Eustis that would be co-located with our psychiatric clinic.
Okay. There's an outpatient facility there?
Yes, sir.
All right. Thank you. Any questions for Mr. Cherry, excuse me? Jerry. You guys are You guys are killing me.
I went to a meeting today at the Florida Hospital Association, and on my name card, it was Jen Cherry, J-E-N. So when a question came to me as Jen, I said, well, that's my new name. But
All right. Well, thank you very much.
Thank you.
And again, we're trying to clean up some of these ambiguities in the current legislation, and hopefully we'll be able to help.
Thank you.
Ken?
Yes.
Mr. Cherry, you got that, you applied for that grant because of Dr. Petrovis, right? He made you aware. And none of us knew anything about that $20 million that was available. You would be eligible for at least $4 million, right? Through that grant? Thank you, Dr. Petrovis.
I suppose there was no limit on what you could apply for. I'm not certain.
I read that it was, you could qualify up to $4 million.
All right, but we...
Congratulations.
Well, thank you.
For getting
We'll be
something.
happy if we get the $320,000.
Yeah.
Great. Thank you very much. Next item on the agenda, we've talked in practically every meeting about the hospitals, the acute care hospitals that are receiving funds from the tax district, participating in various Medicaid matching programs. There's a buyback program, there's an exemption program, the lower income pool, and we've got a gentleman here by the name of Eric Fussman who's come and presented to this board previously, I think about a year ago, and he's heavily involved in that process up in Tallahassee, and I asked him to come. He offered, and I accepted him coming and giving us an update on what's going on up there with the matching program this year.
Sure. My name is Eric Fussman, and thank you, Mr. Chairman, board members, staff. The legislation does, of course, allow you to continue participating in the match programs that exist through the Agency for Healthcare Administration. Currently, the district participates in 3 different programs: the low-income pool program, there's the exempt program, and the buyback program. Each have their own separate requirements and purposes, but they all currently are available. They'll on a going-forward basis. Actually, the first meeting of the Low-Income Pool Council, which really coordinates all 3 of those programs, is next Thursday. And I talked to the staff before the Low-Income Pool Council this afternoon, and they've just come up with some of their initial numbers they're going to be sharing with low-income full council next week, and we're on their list for the district to participate in that program. And so sometime probably late next week, your staff will receive from ACA copies of draft letters, what we call letters of agreement, from the ACA staff to review and to refine and to submit.
Okay, so we will have something by the September
Yes.
budget meeting?
Yes,
Okay.
absolutely.
Okay, good. Are you anticipating the similar match, the percentage, or is that really dependent upon?
They have not, they wouldn't tell me. I expect that it won't be it certainly won't be any larger than what was last year. It could be a bit smaller, just because all dollars everywhere in the state program are all shrinking. So, we'll know that probably next Thursday. We'll know what the exact numbers are and share that with you.
Okay, great, thank you. Any other questions? Yes, I know.
I don't understand what you're talking about now. Are you talking about the hospitals or this board and what we're trying to do?
So the letters of agreement actually are signed by the board. So the agreement is with the district and the Agency for Healthcare Administration, but it does directly benefit hospitals, Waterman and LRC. That's correct.
In our new legislation, though, it says something about we can only fund patients that have no other, that are not qualified for any other government program. So what you're talking about is the buyback program for Medicaid.
Correct.
Well, how would that make the hospitals eligible with our new legislation then? When it exempts Medicaid? They might be eligible for LIP, but I can't understand how they'd be eligible for Medicaid buyback.
Well, and I think, I'm not sure I can answer that question.
I can.
Can you? Okay.
I've actually answered it more than once, to be quite honest with you. I was hoping that maybe you could do it in a different way. We are not specifically reimbursing Medicaid costs. We are reimbursing individuals who qualify under the new requirements, under the new legislation as indigents. And rather than us sending the money directly to the hospitals, they have asked us to send the money to ACA to participate in these Medicaid matching programs, which then go back, those funds then go back to the individual hospitals as they bill for Medicaid procedures that are submitted. So we're not paying for Medicaid patients. We are reimbursing for qualified indigent care costs, but just sending the money to a third party, which then goes back to pay Medicaid.
Right. It does not change your oversight for how those dollars are used or what they pay for, but the legislation definitely directly authorizes the district to enter into those agreements with ACA for those programs.
It's a loophole.
It's provided for in the legislation.
That's your description, and that's not a position.
I just don't understand it. Somebody's going to have to get with me and explain it.
Well, it's been asked and answered many times, and I apologize if you don't understand, but I would recommend that you do so on your own time, because I think it's just wasteful. I believe everybody else on the board seems to have a pretty good understanding of it. It's been explained many, many times, and I really don't understand where the issue is. So, thank you very much. Any other questions for Mr. Preston? All right, thank you so much for coming.
Sure.
We look forward to getting the information at our September budget meeting. Next on the agenda is Farland Houseman from Moore, Stevenson, Lovelace. And I want to give a little bit of background before I ask him to come up and speak. As you'll recall, that when this legislation was passed and went into effect in April, we had our first special meeting, I believe, was it June or May? I don't remember. May. We've had so many. But we were in having conversations with the drafter of the legislation, or Representative Metz. And there's even language in the legislation suggesting that we try to work out an arrangement with the county where they can provide some of the audit service, or to at least look at them as an alternative, hopefully a cost-efficient alternative. And so that was the intent from the get-go, was to try to get the county to participate. There is an area within the county government that reviews and approves charges that come into the county for services provided outside the county for indigent patients that live within the county. And they fall under the exact same HICRA guidelines as we will, or we do, with the exception that our legislation calls for a 200% of poverty level income threshold as opposed to 150 within the HICRA guidelines. So that was always my intent, was to try to involve the county, and I've had multiple meetings with them since prior to our last meeting in July, and I've had 2 other meetings since then, including, we actually also included, the county manager was there, Leslie Campione, the chairman of the Board of County Commissioners, was in attendance at both meetings. In the second meeting, after it was suggested at the first meeting, the county or the state health department representative Donna Gregory would attend. And the bottom line is that there wasn't any intent, or not necessarily intent. There was no agreement by the county to provide the services. They don't want to participate or feel like they can't. The state health department thinks they cannot. Think there may be a conflict if they're contracted with the county for other type services. So the bottom line is I felt like I spun my wheels significantly over the last several months in trying to get the county involved. The third-party administrator that came in and made a presentation, and then also submitted a proposal to provide all of the audit requirements in the legislation, including the eligibility as well as the determination of the lower of cost or Medicare reimbursement. Their costs were prohibitive. And the idea was that maybe we can break up those services and have, we didn't need to, in our opinion, I think the board agreed that maybe we did need to replicate the system that was in effect at West Volusia Hospital Authority, which is what that third-party administrator was trying to recommend to us. Their total costs for that program were well in excess of $800,000 for the accounting and eligibility and claims adjudication process. Granted, they handle about double the amount of tax proceeds, but it's still a very prohibitive number. So we looked at I went back to the third-party administrator like I was asked to do at the last meeting and say, can you provide just the financial part of it? Maybe we can find, at that time I was still hopeful that the county was going to be able to provide the eligibility services, and I was going to ask the third-party administrator to just bid on just the financial piece. And they indicated that their system was built on an eligible patient. They would have, they could break it out, but they would have to be supplied with a list of eligible patients to enter into their system before they could process any claims, and it just got very, very complicated, and it didn't sound to me like that was going to be a solution. And if you recall, their costs, I think, were a minimum of $10,000 a month, and some add-on costs as well that could have increased. And their eligibility, the estimate on the eligibility side was also in the $40,000 to $50,000 range, based on the number of patients that we think we're going to be seeing. So their estimated costs were somewhere in the neighborhood of $200,000 to anywhere up to $250,000 or $300,000. Since the meeting, I had previously been provided a couple names by Diane Harden. I saw her walk in just a little bit ago, and after the meetings with the county indicated that wasn't going to be didn't look like that was going to be a solution, I contacted both Pershing Yoakley, a firm up based out of Knoxville, Tennessee, that has multiple locations. The most close location, I believe, is in Tampa. And the other firm was Moore, Stevens, and Lovelace, that's based out of Winter Park, Florida. Now, I believe Moore, Stevens, Lovelace provide services to the county, to Lake County. I'm not sure if are they the financial auditor for the county?
Yes.
Okay. But both firms have significant healthcare experience, auditing, accounting, consulting, you name it. And having conversations with both of those firms over the phone, I immediately, was kicking myself for not calling them first. I think that, in my opinion, that I think that they're going to be able to provide the services that we need for the entire eligibility and the financial piece of it, hopefully a significantly more efficient and less costly number or amount that was proposed by the TPA. So with that, I've had conversations with Doug Arnold, with Persian Yoakley. He had provided a draft of the proposed work plan outline that I had provided. I think you got that today. The reason I didn't send it out until today was because he had indicated that he may be making some changes to it and was going to try to get that to me early, and I did not receive any changes. So around noon or so, I sent this to Ms. Kirsty's office to have it sent out to the rest of the board. So that's a general idea, and it's very similar to the conversations I've had with Moore Stevens Lovelace. They haven't put anything in writing yet, but I've had some detailed conversations with them as well. And since Moore Stevens and Lovelace was just down the road, Mr. Halleckman was gracious enough to offer to come and talk to us a little bit about what we're facing and what their recommendation may be, and to answer any questions that the board may have. So with that, Mr. Farland, Halleckman, please come forward.
Well, good evening. I think Ken pretty much summed up what the status is. And with that, I'm open to questions.
I know that we had talked about originally, and we were talking about sample size, and I think that our costs are going to be determined based on sample size. And we had talked about an industry standard. I think that may have been what was in a proposed set of procedures that we had discussed previously. And we talked about a 25 to 30 item sample, and there's a difference between a control sample, a testing sample, and a substantive test. And I'd like, can you address that and the benefit of going to the substantive test and you can't give a guarantee. I know that's not a good word, but
Well, first on the two different types of sampling, if you don't expect that you're going to have any error rate that's significant, certainly not pervasive, then you can take a much smaller sample. If you can get to 30 or even 60 items and you haven't encountered an error yet, then you can make an inference from that result that you don't have any pervasive problems in what it is that you're sampling in the population as a whole. Now, if you do expect that there might be some errors and that you want to do something like record an adjustment to the reimbursement as a result, then you're going to want to have something more statistically valid. In fact, you're going to want something that is statistically valid and that's not going to be able to be challenged by either party to the transaction. And so there we're talking about a larger sample size, and looking at the numbers, just to put some numbers to it, Ken has suggested that there might be 3,000 encounters from each of the hospitals over the course of a year. So with a population of 3,000, a statistically valid sample, that you would have a 95% confidence level that what you're extrapolating is a hard number. We're talking about a sample size of about 340 items. Seeing that this is going to be done on a quarterly basis, if you take 340 divided by 4, you get 85. Following me? So we can look at 85 items each quarter from each hospital. And by the time we get to the end of the year, we'll have a 95% confidence that we either have a good number, or if we don't have a good number, we'll know how to adjust. We'll have an extrapolation that we can use to adjust the number to a good number. And so practical and efficient way to handle this is to do it with a sample size of about that. And, if we end up with fewer encounters, we can adjust that in the fourth quarter, look at fewer items in the fourth quarter and so forth. And that at the end of the year, we can do a true-up with the hospitals. In other words, if they've submitted information that for encounters that didn't meet the criteria for reimbursement, then we'll be able to project what that error rate is, and in terms of dollars, and adjust the amount of dollars that are going to the hospitals in that fourth quarter.
Okay.
And that seems to be the simplest, most practical approach. With regard to medical necessity.
Yeah, thank you. That was going to be my next topic.
Okay. Well, with regard to medical necessity, I'll agree with everything that the other folks that have been up here have said. Is that it's just real hard to, in hindsight, challenge the clinical assessment made by a licensed practitioner who actually had direct eye-to-eye contact with the patient and had an examination and said that this was a medically necessary procedure. If they didn't have that and they wrote a script for a procedure, that would be malpractice and fraud and abuse and all kinds of terrible things. So I think that the most practical way to deal with the medical necessity language that's in 1299 is, and I suggested this, is look, the hospitals are looked at by a number of different regulators, and I think we can look at their accreditation reports, their peer review reports. We can look at results of CMS audits, or even interview their, in fact, I would insist on, I think this is the right thing to do, is to interview their compliance officer with regard to any ADRs that are going on now, or any...
What's an ADR?
It's desk reviews from Medicare. So if there are investigations of their billing practices going on, we would look at the details of that and decide, okay, do we either have a serious fraud and abuse pervasive situation here, or not? And my expectation is that we would not. If there is, then we'll be reporting to you immediately what we find.
The other audit, auditing the charges, are you going to be, I'm assuming you're going to be accessing the patient file or the chart or whatever they call it,
Right.
Anyway. So you're going to be in there looking to see what services were actually provided or documented in there, and then comparing that to the charges that are listed on the sheet or the worksheet that's submitted by the hospital. So how easy would it be to also look at, a record or the authorization from
The physician script? Yeah.
And
While we're there,
do that too,
yes.
in addition to looking at these other reports?
Correct, yeah. My expectation is that you'll, in the final work plan that's agreed to, is that we will check to see that there is a script from a licensed practitioner, may not always be a physician, from a licensed practitioner authorizing the procedure in the file. And then, of course, we'll go to the Medicare fee stream and see what the Medicare payment is, and then we'll use the cost and charges ratio from the most recently filed cost report to determine what the cost is, and make a list of which is the lower of, and make sure that that's what ends up being the number that's being reimbursed. So I think that's the most practical approach to getting you to where you're in full compliance with 1299, and you're not using resources that really should be going towards caring for the indigent in this process or other, having it eaten up in administration. Interesting that you had mentioned West Volusia, because we're the CPAs for 3 other health districts, and West Volusia is one of them. And before Health Systems 1 was engaged, they also had issues And we did a very similar type work for them. This was maybe 10 years ago.
What kind of work does Dreggers, Rigby, and Teal do for them? They're an accounting firm that came in.
Right. Yes. What they do is the bookkeeping.
Okay.
They're not the auditors.
Okay, so you actually prepare an audited financial statement for the district?
Correct.
Okay, I got you.
Correct. Yeah. They have one firm to do the bookkeeping,
Yeah.
or the audit.
You're auditing the auditors?
Yeah.
Okay. Any questions for Mr. Howland? I hope that the rest of the board sees the benefit. Again, it was like a big weight lifted off my shoulders when I had these conversations with him and the firm out of Tennessee. I think that having one-stop shopping and having been done by CPAs, well-respected CPA firms, I think is good. We really won't have a good estimate on the cost. Based on I'm not going to hold Mr. Howland to it, but he gave me an estimate based on the numbers that I provided him, 3,000 encounters from both Leesburg and from Waterman, and the estimated sample size that he just mentioned, it could be in the neighborhood of like 50 to 60,000, as opposed to a couple 100,000 from the TPA. So even if that number is too low, and it could be adjusted upwards, and for instance, that's one of the items on my agenda is to determine what, if anything, we're going to require from an audit standpoint for the recipients of proceeds less than 10%. The House Bill 1299 only requires us to audit the recipients of tax proceeds in excess of 10% of the total, which heretofore have only been the hospitals, and I would presume it appears as though that may be the case this coming year as well. But if there are a couple of other providers that if we're some way able to come up with a way to fund the free clinics or give them some money, Lifestream Behavioral Center has always received 5%. There may be additional funds there. We can get their clinic included as well. So again, we've got the possibility of several providers receiving less than 10%, and we have to make a decision as a board. Do we enact that? It says we can. We can audit anybody that receives anything, but we're only required to audit those that receive 10%. So that would also have an impact on your cost. I mean, I would presume that we're asking for similar information from any provider that needs to be audited, and both or all of them that I've spoken to have said, it may be difficult for a free clinic to come up with the information that a large hospital can, with a click of a few buttons. But they did indicate that they were going to be able to submit a list of charges. They do track their patient visits by codes and services that are provided and what have you. So I would think that would also be available. We have other issues that we have to get over with regard to the Medicare reimbursement. I think I had a meeting this morning with a phone conference with the hospitals, and it was indicated. I brought up my concern with the Medicare reimbursement, the lower cost of Medicare reimbursement for the free clinics. Since the clinics licensed providers are not being paid, how can we compare cost to Medicare reimbursement? And I was told that there is a clinical and a facility fee, and there's a global reimbursement for Medicare reimbursement, but it's broken out for the physician and for the facility. Is that something that we can use with regard to auditing the free clinics if we have to?
Yeah, I would have to think about that one. I can't shoot from the hip on that. But I know that the Broward, both North Broward and South Broward, fund clinics. I don't know how they go about doing that, but we can certainly talk to them about how they get that done.
Okay. All right. Just thought I'd throw that in there just in case you knew, because I know that we're going to be discussing that here shortly. Any other questions for Mr. Allen?
Yeah, Mr. Chairman, I assume we're going to get two bids from both of these firms for this. Do we need to button down the parameters a little bit more as far as sample size, or we're sure apples to apples on both of them? Or we can specify a little bit rather so that we have comparative confidence here?
I think that...
Is that in line, whether we want to say 320 samples or 3,000 encounters? Or
I think that that's what I would do. I'd ask each one of them to present a cost estimate based on the 3,000 universe from each hospital, and if we decide as a board that we need to audit the other recipients of the tax proceeds, we might have to tell them to consider that as well.
But they'll be using the same parameters and all, and one person
Right.
may take 600 samples, the other 320, so that
Right, I want to make sure that we're comparing apples to apples, right?
Okay.
Sure. Any other questions? None? Okay. Thank you, Carl.
I appreciate it. Thank you.
We'll be back in touch with you shortly. The next item on my agenda was proposed July 1, 2012 through June 30, 2013 audit period. It's something that hasn't really been discussed. Our fiscal year for the tax district actually begins on October 1 and runs through September 30 of each year. The hospitals have indicated that they would be able to provide their list on a quarterly basis within 60 days after calendar quarter end. And my hope was to have 4 quarters worth of data for next year's board to consider at the budget meetings in September. Accordingly, if we stayed with our fiscal year of October 1 through September 30, the 4th quarter wouldn't end until after our budget meeting, the board's budget meeting next September. So we wouldn't have 4 quarters of audited data to refer to and make a decision based on whether we're going to keep the millage rate where it is or whatever. So it was my suggestion, and I've actually talked to both hospitals, and they have retroactively been operating under the new documentation requirements since July 1. And you'll stay with me here, the 1st quarter will be July 1 through September 30th, and then October 1 through December 31st will be the 2nd. The 3rd one would be January 1 through March 31st, 2013. And the 4th quarter would be April 1 through June 30th. With a 60-day time frame, and maybe we can skinny that up a little bit in the 4th quarter, maybe the information, if we have to get it, in 45 days on the 4th quarter, maybe we can do that. But we would have the 4th quarter data sometime in August, near the end of August, and it would allow the audit work to be prepared in the first few weeks, within hopefully a 2 or 3 week period, late August to mid-September, and final reports would be available to the board for the board to consider next year. So I would at least like to discuss that, and if we have, hopefully we can get some acquiescence from all the board that will be the audit period that we'll be looking at. So with that, I'll open that for discussion.
Why not?
Does that audit period, you're not asking us to change our year, it's just a matter of reporting the status of the audit, so I would agree with Mr. Brown, why not? If that's in fact the case.
I would just hate to make a decision based on incomplete data. If it's nip and tuck with the reports that are received for the first 3 quarters, makes it look like we're going to be close as to whether there's going to be enough qualified expenses incurred to cover the tax proceeds. I think we want to have that information in front of us before we make the decision for the next fiscal year's millage rate. So this is the way to do that.
There's no legal ramifications at all as it relates to changing an audit period or directing that to our attorney.
Not that I'm aware of, Mr. Byers.
Any other comments, questions? Do we need a motion to accept that? I think I would like one.
I would prefer to have one.
Okay. audit period run from July 1 through June 30th for purposes of determining qualified infant care under the requirements of House Bill 1299.
So moved.
We have a motion by Mr. Byers. Do we have a second? Second by Mr. Bone. Any further discussion, comments? All right, hearing none. All in favor of that motion, please signify by saying aye. Aye. Opposed likewise? Motion carries. All right. Moving right along here. All right, here's the tough one, though. The next one was do we require audit of providers receiving less than 5% of the tax proceeds? And we've already talked about some of the potential issues with a couple of the clinics, but primarily St. Luke's with the dental. And I don't know, is there another legislative session in Tallahassee where they could make a change to the existing legislation, or we're going to have to wait till next year? Yeah, that's what I thought. So I don't know if what the thoughts are from the rest of the board members. We can be within the letter of the law as written by not requiring audits, but I think we just need to be careful. I don't want to be criticized for knowingly circumventing the documentation requirements and determination of the eligible cost. By executing or following a loophole, so to speak. I mean, we don't have to audit them, but if we know for a fact that some of their costs are related to dental, or if there's it's a free clinic and we're comparing costs to medical or Medicare reimbursement that includes a reimbursement for the time for the provider, is that an issue that we just want to overlook as a board, or are we going to hold their feet to the fire and try to get documentation from them similar to what we're getting from the hospital? Anybody?
Yeah, I'll talk about it. For one thing, we need to figure out when we're going to start qualifying these providers. We have not, here we are, we're concerned about auditing, and we've never come up with anything to qualify providers. Now, I would very much like to have St. Luke's. I would like to see us do some funding with St. Luke's. They can just leave the dental out until we get it straightened up with the legislation.
Do we know, does anybody know the intent of the exclusion of less than 5% when the bill was written? Was that ever addressed as a line item of why that was even inserted?
I'm going to try to put words in Representative Mentz's mouth when I probably shouldn't, but I think that maybe it was his opinion that when you look at the dollar amount of the overall tax being, last year I think it was $8.6 million, so 5% would be $430,000. I don't know that there's a clinic out there that, I think that probably, I'm looking at the hospitals, where the Leesburg Clinic and the Eustis Clinic, were their operating budgets in excess of $430,000 for the year? I didn't think so. So I think that, those are the two largest clinics that we were aware of, and I think that in my conversations with Representative Metz, I think that it was his intent to try to include them. And that's why, and I think at the legislative delegation meeting, the representative, Marlene O'Toole, had some concerns about the sovereign immunity, and he threw that information in there at the very end to try to get us over the hump. And I think there's still issues there. So I think the intent was to include the free clinics with maybe the understanding that it's probably wasn't going to be a huge number to any one of them. So do we want to cut in some slack from having to maybe go out and hire a billing person or another administrative staff to come up with all this documentation that's going to be required? And again, that's I'm surmising, but that's what I would think.
Mr. Chairman?
Yes.
I also thought that it wasn't 5%, I thought it was less than 10%,
You're right.
right?
It is.
Okay.
Sorry.
No, that's all right.
That is a very good point. It's less than 10%. So it's even bigger number, 860,000 based on last year's numbers, and I don't know what it's going to be this year. I understand that property values are down about 6% overall, so it should be a little bit less this year. So, Mr. Bowman?
My light's not, that's just on, okay, my light's not working there. My thought would be that it would be something that, on a case-by-case basis, maybe, I mean, depending on what the provider, the background of the provider, the history with them, how much they're getting, and, I mean, if we start saying that you're gonna require them to do an audit if they get less than 10%, well, is it everybody less than 10%? What if we only do 1%? So we'll start getting into that discussion of, okay, where are we going to require the audit? So my thoughts are that, on a case-by-case basis, if it's under 10%.
Well, go ahead. Anything else? Gary?
It's logical to me, case-by-case basis. I'm inclined not to require the audit, but I think we're going to have so few clinics that will have this opportunity, and we should have that option, and case-by-case seems to be logical to me.
Well,
we can do that if we can structure as such.
Right. I mean, the other side is that, this first year, the added transparency and accountability that's been provided by this bill, do we really want to try to get our hands around the actual cost, and maybe invoke that audit piece for everybody for the first year, and then kind of see what we come up with, and then make a decision on a go-forward basis about whether any recipient of less than 10% gets audited. So I'm just throwing that out there. It's another school of thought that probably needs to be considered, because we really don't know what we're going to come up with. The new legislation or the HICRA guidelines are severely limit or reducing the pool of indigents. I mean, it's a very narrow description, and so we really don't know what we're going to find. The good thing is that the legislation does have language in there that says that if the payments that are made to the hospital exceed the documented indigent care cost, that they are required to pay it back. So we've always got that to fall back on. That could then be used in determining what the millage rate is going to be on a go-forward basis, for the following year. So I'm not necessarily concerned that they're going to be getting more money than they deserve, because ultimately, they're going to have to document it all in one way, shape, or form or another.
I mean, that kind of goes with what I was saying. I mean, what I was saying is that if you're going to say, do we not require for somebody under 10%, well, at what point do you not require it? Everybody under 10% or what percentage? So, I mean, the other way to look at it is to say, we'll just require that everyone will have to do an audit until there's a history established, and then once there's a history established with someone that's maybe receiving 2%, let's say, then you say, well, based on the history of audits, we're not going to require you to have that. But if your question is, do we require audits of everybody under 10%, or is there some?
Yeah, that's the question.
For everybody under 10%.
And in addressing Ms. Banner's point about qualifying the clinics, each one of them have financial statements that I would presume that they're going to be bringing into us with an estimate of the budget. I think Ms. Berry had indicated she has a detailed budget for St. Luke's as actuals for the prior year and the estimate for this coming year. So we'll have some information, I think, that we can use to determine whether we're going to support them or not, and try to direct some funds their way. There's so few of them in our tax district that I think we all have a pretty good idea who they are and their needs. So I think that should probably come into play as well.
Maybe compromise the first year to do it, and then thereafter optional.
Well, I'd say, give it some thought. I'm okay with that, but give it some thought, and maybe we can come to a final conclusion at our first meeting in September. In the meantime, I can ask the clinics that do want to participate. Hopefully, we'll have some information from the state, but Mr. Madison said they've been requesting it for several months and haven't got it yet. But the legal opinion, I think, will go a long way as to whether we can send funds their way this year. The lump sum option does seem to be the way out, or the exception that we can maybe hang our hat on. But I would like to have the legal opinion to that effect before jumping on that, I think. Don't want to get sued.
Mr. Chairman?
Yes, ma'am.
We have just pondered over this bill for 3 months now, and it just seems to me like we're not getting anywhere. And all due respect to Meredith, she did mention when we started this that she had to consult with Lewis Stone to analyze the bill. And I was just thinking, rather than us just worry over this, why don't we hire a healthcare attorney? And I'll put that in the form of a motion. I think that we should hire a healthcare attorney. And these attorneys are more schooled in this area than, I'm sorry, Meredith.
Oh, I believe we have a motion in front of us for the board to hire a healthcare attorney to help us interpret the legislation before us that we were supposed to comply with. Do we have a second?
I'll second that.
Okay. I'll open it up for discussion.
How much would you want to budget for this attorney? Aaron, do you have any idea on cost at all?
I just have no idea. I just know that we have spent 3 months now, and of course this is a very complicated subject that we've gone into. We've had these people, this Mr. Smith that came and talked to us last month. He was just pleading, well, he wasn't pleading. He just said that he is booking people 6 months out, that there is such need, and we are just discussing and cussing primary care and medically necessary and all these terms that are strange to us because we are not in the healthcare business. We have none of us. We're all beginning to get a little more education, but I know that a healthcare attorney surely could help us. And how much, I don't know, but I don't think I want to pay $500 an hour. I think Lewis Stone charges us $3, does he?
But he's not.
I don't know what you charge us, Meredith. $220? $220? Okay.
Are you done? Okay. I guess maybe I have a little bit different perspective because I've been so involved with the nitty-gritty, the discussions over the last several months. We've been invoking some minds, some pretty experienced healthcare minds, whether they're working with the hospitals. There is an attorney sitting right there, Mr. Braun, that works for Leesburg Regional, the hospital, Florida Hospital, I believe, has been talking. They have a home office, and I'm sure that some of this has been run by their legal counsel. They've requested an opinion from the state, from the attorney at the state level, for an opinion on the sovereign immunity. Meredith's done some research. We've got accountants, Moore, Stevens, and Lovelace, the firm in Tennessee, Pershing Oakley. I mean, we've got a ton of much more qualified people than I am looking at it, and they're also somewhat scratching their head, but because there isn't a black and white answer to this, I think ultimately that, and I've said it before, is that, God bless Representative Metz for the attempt, but, and I think that the detail that was necessary just isn't in the current bill. I think there's going to have to be some changes in the terminology in order to make it more clear. And again, I personally am in favor of trying to send funds to the free clinics, but I just don't see how we're going to be able to do so without, getting some help. And I don't have a problem in hiring a healthcare attorney that specializes in it, but like Mr. Brown, I think I want to limit the cost that would be so involved. I'd have to check around and see what kind of, if there's any local attorneys with healthcare experience that we could deal with, or if we have to go outside of the local area. But I just wouldn't want to give them just an open wallet. I mean, it's an 18-page, I think, piece of legislation. It's going to take some time to go through, but I would definitely want to limit the cost that we're going to spend, because I think they're going to come back and say, you need to change the wording, and if you're going to try to support the free clinics, you're going to have to change the wording in the current legislation. So,
I'd like to add, I tend to disagree with Ms. Banner's statement about us just kind of not moving forward or anything. I think we've gone light years at every meeting, and there's so much information that has to be determined and talked about, and we're doing that. We may not be getting answers for everything we discuss in one meeting, but by the next meeting, thanks to the efforts mostly of our chairman, coming back with tremendous resources of information and additional options that we didn't have a month prior. I think because of that 18 pages, we're moving faster than I actually thought we would be able to move. It does take time. I don't know that having a healthcare attorney is necessarily going to speed that process at all, personally. I mean, I think maybe we are missing the boat. Maybe that person, that attorney would be able to answer a lot of questions for us in a short period of time. But I've been very pleased with the efforts being brought forth and the people that we've had come give us direction from the audience and answer the questions. A lot of the delays are outside of our scope. We don't have control over when that attorney in Tallahassee is going to submit an opinion. Still trying to wrap our arms around the opportunities of determining how the free clinics are going to adjust their billing unless we get this block payment type thing. I think that is the answer as well. I would agree. So, without that suggestion, it would not have been occurred to me to reach outside for an attorney outside.
And we haven't heard from Mr. Braun all night long. We have a healthcare attorney sitting in our midst. Can you come up and give your opinion on what you think a healthcare attorney might be able to bring to the table? I mean, I know that you are one, but you're also the general counsel, but just would be interested in your opinion.
Thank you, Mr. Chairman. I'm Phil Braun. I'm General Counsel for Center Florida Health Alliance. A lot of it is, as you said, the legislation, in my opinion, could be a little more clear. I think, I don't know that a healthcare attorney, as much as maybe a governmental attorney might even be helpful to try to read the legislation, but I think you've done a good job. I think you've gotten about as far as you can. I can't imagine you're going to find an outside healthcare attorney that's going to not charge you more than $500 an hour. I mean, if you're looking for a true specialized healthcare attorney, they're not cheap. I can't say that they would give you much of a different opinion on than where you've got it. There is nothing in the legislation, there's nothing in statute or any other legislation that tells you what a licensed primary healthcare clinic is. I think you could probably interpret the free clinics as one, but again, the sovereign immunity question is out there. That's unclear. If the Department of Health, who oversees sovereign immunity, if their attorney can't tell you the answer, no other healthcare attorney is going to be able to tell you the answer. And they are the authority. They are the authority. What they say is what will be interpreted, and you have to go to an administrative law judge to get that authority overturned, in my opinion. Your biggest issue, as far as probably that I've heard today, is the lump sum payment.
how you go about doing that when it's very clearly defined in your bill what indigent health care is, and you have to only pay for indigent health care if you try to pay for construction or you try to pay for something else. And if you do it in a lump sum and you don't tie it back to that indigent care that was provided, you're going to probably run a risk of being in violation of that law. But a healthcare attorney, depending on what you're looking for, I mean, when I think of a healthcare attorney, you're talking about healthcare attorneys who deal with anti-kickback, Stark, licensure issues, licensing regulations. This is a bill that you're trying to interpret, and sometimes, as we all know, the legislatures don't do a great job of writing bills. I mean, even though they're probably written by attorneys, and maybe that's why they're so hard to read. I don't, because there's a lot of ways, but I think you've done a great job getting where you come. I mean, I don't know that you get a whole lot out of hiring another attorney. And Meredith has healthcare background. I mean, Meredith is a capable healthcare attorney as well. I think she deals with elderly care and elderly law and understands regulations just as any other attorney. You've got an attorney on your board who could probably attest to that too.
What is Meredith? Can you address the liability issue? I mean, if we make an assumption in order to try to get some funds to these free clinics this year, and ultimately it's determined that we did so incorrectly, what kind of liability is there on our part?
Good question. That's a very good question, and I really don't have an answer for that. And I don't know the answer. I'll be glad to research it, but I don't know. Maybe Mr. Blanc can.
I don't know for sure. It's not research, but I mean, it would typically be, you better have some good faith justification. As long as you have some good faith justification for doing so, I think you're okay. But to me, I mean, the definition of indigent care is your CPA, the independent CPA or auditor, who would look at that. Actually, they can interpret whether that's being paid properly or not. I mean,
I would venture to say for a free clinic that the Medicare reimbursement rate just for the facilities is going to be less than their cost. I mean, normally I would think the cost is going to be the lower of the two.
Yeah, it's a hard thing that the bill, because if the bill had stopped at pay them their cost reimbursement, which, cost reimbursement means you're not making any profit, so you would probably be okay with adding that, or Medicare, whichever is less, really throws you for a loop, because sometimes Medicare will pay you more, sometimes they'll pay you less than your cost. Typically, as a whole, they pay you less. And I don't know why it was written that way, but that's the way it was written. The free clinics, I think part of the problem for them is that they don't bill Medicare. I mean, they don't bill anybody, so they don't bill typically. If they don't count the physician's cost in the service, you're probably right. The cost is going to probably be less because they have very little cost, and actually most of the cost is funded through either the hospitals or charity or donations. I mean, remember, these are free clinics, so their costs are coming from somewhere. They're not paying those costs. They're not paying it for revenue because they don't have any revenue. So you could probably come up with a cost number that's pretty low and pay, but it's going to, again, they've got to meet the HICRA requirements, which are spelled out, and the HICRA requirements will be something that they don't normally document for, that they'd have to document for. But to pay them a lump sum without tying it to, I mean, just like similar to how we're asking to use the matching dollars, which is put in the law, we're kind of saying, hey, we're going to go mow the lawn, and you owe us for mowing the lawn because we met your requirements for mowing the lawn, but we don't want you to pay us directly with the money you owe us. Send the money to our bank, and our bank's going to pay us interest on that money. If you pay us directly, we're not going to get the interest. And that's kind of what you mean. So you could pay a lump sum as long as you tied it to a number of indigent care, as long as you tied it that way.
Okay. Thank you. I appreciate it. I think it further documents that we've got an issue that we have to resolve. I guess we have a motion in front of us in a second. If there's any further discussion.
anyway, next month, we have to decide on the millage that we're going to charge. And then does that mean that this board will not meet again until January?
Not necessarily. I mean, the chairman can call a special meeting any time, and I would think that you would probably want to do that, especially when the audit, when you get the result of the first quarter's audit. I would think you'd want to meet and try to take a look at that, and I would think that's probably would be a good idea for the next chairman to decide. So.
It just seems to me like we're just leaving a lot of strings hanging loose here.
Well, I think
I just don't feel like we've finished anything. I'm sorry, Roger. We might have gotten a lot of good information, but I just don't feel like we have completed anything.
I think there's a lot of frustration on us all in this thing. I think we see the need in lots of different areas, and our hands are tied in so many different ways. What we can do with sovereign immunity, all these things we've discussed in the last 4 months. So there's a high degree of frustration here. We see the need out there in the community. We'd love to be able to try and do more we can, but the restrictions that are continually being placed on us make this very difficult. I mean, I think that's a great question you had about the liability and what we could go back. I mean, that's one of the reasons I think maybe not requiring auditing. Maybe I'd love to try and give the money to where it's required, but if there's a liability factor, sure, it makes me very, very, very cautious to do such. So it's frustrating, but I think what concerns me as much as anything else, I think our leadership position has just been outstanding. And you're talking about reimbursement. I like to do whatever we could to keep Mr. Carpenter around here for consulting or something we can do as we go to the next stage. He has learned an incredible amount of knowledge.
But we do have a budget meeting coming up. You can put a line on it.
I certainly like to try and use money instead of for lawyers trying to do something that can continue to get his advice in some form or fashion. But we all share your frustration. I do, at least. I'm sure the rest of us do, and especially when we see the need and we have the money and we can't get it to some of the people that we want to. I think the legislation in this bill, is the way it was written, makes this very restrictive, and it's frustrating.
Thank you. If I recognize you, are you going to be the only one from the public to speak?
I don't know if anybody else wishes.
Go ahead, Dr. Petrovitz. You've had some really good comments over the last couple months. So.
Tony Petrovitz, and I'm really speaking to you not as a physician or a lawyer, but as a citizen. And I think I brought up at the very first meeting where you all were discussing this entire issue of how to implement the new legislation, that it would be important for you to have a healthcare attorney as a consultant. Because obviously all of you bring certain perspectives that are outside your expertise. And to not have the advantage of having that independent counsel give you direction and advice in a field that is in itself complex, I think is really a problem for you. The other thing I reminded you of, and I hope you won't feel badly about my comments, is that you are here representing the public. You are elected by the public. And as such, you should be the stalwart champion of that representation. And with all due respect, and I think you have done a monumental job, Mr. Carpenter, but with all due respect, I think that the advice that you need should not come from those who are stakeholders and have a direct interest. You certainly can hear from them, but they should not be the final arbiters, and you shouldn't weigh heavily upon their advice. What you need really is your own independent thinking brought about by independent counsel. And I have depended upon the hospitals and the hospital's attorneys as a physician over many, many years. But in this case, where so many dollars are involved for the public's benefit, you really need to represent the public. I hope you'll take my comments as constructive rather than destructive. If you have any questions, I do want to address the other issue that I'd like to say a comment about is the audit that may be necessary or may be imposed by this board on those clinics that are 10% or less in their amount of stipend that they might receive from you. One of the things that you have constantly questioned in your own minds is how much do you want to put into your infrastructure in terms of the auditing. And now you are asking these clinics that are taking a relatively small amount of money to contribute a portion of those funds back into an auditing process. The very thing you, Mr. Brown, have talked about. And that is, why waste money on all of this infrastructure? Well, unfortunately, the infrastructure is a vital part of what medicine is all about and the delivery of health care. So, with those comments in mind, I promised myself I wasn't going to speak, but representation of the public is always important. And that is what is going to give this board the most credibility in whatever your decision